speaker, and we have a very patient young doctor, Dr. ROHIT, who was just erroneously made the last speaker from Sri Krishna Netralaya in Aurangabad, Maharashtra. And he's also going to tell us something very relevant to all of us: cataract and ectasia. What are the pre-operative and the intraoperative challenges? So on to you, doctor.
It's almost a session which has been running since last 2 hours, and everyone is stuck up and everyone is so engrossed with it. So coming to the last part, cataract and ectasia, what could be the pre-operative and intraoperative challenges? At the outset, I would like to thank Dr. Chitra and AIOS. I am thankful to Dr. NR Madam, whom I had worked with, or she was my teacher at Shankar Netralaya. So the main problem, we had been discussing keratoconus all throughout, and a lot of things has been clarified all throughout. So the main problem is IL power calculation and the refractive outcome in ectatic corneas. So the 3 pillars that we need to look, what I would emphasize is the age of the patient, the stage of a keratoconus or ectasia in general, and whether the keratoconus is stable or is still progressing or unstable keratoconus. So the age as such, it could be a young patient, middle-aged patient, or an old patient. The stage of keratoconus, it could be mild, moderate, or a severe. And what we need to look at, stable or unstable cornea, or stable or unstable ectasia as such. So a lot of things depend at what stage, what age the patient presents to us. Like in young patients till 35 years of age, it's a mild treated keratoconus and stable K readings. As we had seen all through.
Maybe you should switch off your video because you know the network is weak at your end, and you have to unmute yourself. You got muted. Unmute yourself and maybe switch off your video. Maybe we can hear you more regularly.
Okay, now you're able to listen me?
Yeah, yes, we can.
Okay.
Yeah.
Sorry.
It's not moving?
Yeah, okay. So in a young patient, you need to get your topography done. First and foremost, confirm whether the keratoconus is stable. And then you do a optical biometric comes into your picture. The more probably what you are going to rely on is a Hegel formula, and you can combine it with Shamas or Holade too. We need to make sure that all the readings are in a similar range where you can have a rough assessment that your readings are reliable. Whenever you have a progressive thinning, more than 5% loss of pachymetry, it indicates that you are still dealing with a progressive keratoconus or increase in a.
Can you switch off your video and talk? There is a
Sorry?
good, can you switch off your video? Switch off the video and then maybe you'll be able to talk continuously. You have no mute and stop video. Mr. Shari, could you help him?
Stop video, okay.
Not your the presentation. If you are not seen, and then sometimes it becomes better.
Rohit, you have the mic and the video option in Zoom, right? Through which we see your face and hear your voice. Just keep up the mic alone, unmute the mic, but you stop the video so that we don't see your face. The reason being when the connectivity is less, it helps.
I got you. Okay, that's better.
Yeah.
Okay.
Now it's better. Yeah.
Yes. So when you are seeing at unstable cornea, obviously, as has been discussed previously, you need to stabilize the cornea. To stabilize the cornea is obviously by a CXL or corneal collagen. Cases are very steep. You need to combine you need to do a CXL plus, which will be a CXL and combined with the ICRS, or a CXL with a TCAT, so as to make the surface more stable or better, or reduce the astigmatism as such. After any sort of corneal intervention, wait for minimum 6 months before you actually plan for a cataract surgery. Middle-aged patient with a stable or a moderate, stabilize that your keratoconus is stable in a relatively middle-aged patient more than 40 years, we don't expect keratoconus to progress further. And sorry.
Can you change your network to your phone? Sometimes, then.
Yes. You're able to listen me now?
Yeah, yes, no, it's coming in breaks. Yes, go ahead.
Okay. So the toric IOL would be an option. However, in the cases of irregular cornea or irregular astigmatism, even toric IOLs won't give you a satisfactory results as such. So wherever you are looking at a very steep corneas in a range of 55 or something, you need to treat the cornea as such. How we are going to reduce the K value is by ICRS or intracorneal ring segments. And then you wait for 3 months minimum, repeat the pentacam or optical biometry, and then you can plan for a cataract surgery or a phaco with a toric IOL. However, you might have to combine it with a DALC and a phaco with an intraocular lens implant. And at times in a patient who has already have a scarring, either you can think of a manual DALC, or you might have at times to combine go ahead with a penetrating keratoplasty with a cataract and a IOL implantation. So this is a small video clipping where we had been doing a DALC combined with a phacoemulsification and IOL implantation. As you can see, there is an apical scarring, and like ICRS or toric ICLs won't be won't be a suitable option. You need to remove the obstacle or the so this was a patient who had a central scarring, which gave me good enough visualization for my cataract surgery or phacoemulsification. Close my incision or phaco incision with a single suture and then proceed with a manual DALC. So it's a peel and groove technique that we do in a manual DALC. You put a small air bubble and try to keep your dissection and start from the periphery and then move on to the center. So once that is done, you just run through. And your routine suturing as such. Patient who has already undergone ectatic corneal surgery like cross-linking or ICRS, or you are looking at RK patients, or a patient who already has an ICL and a cataract as such, or a post-PKP patient. So what you need to look for in a post-cross-linking, you need to wait minimum for 6 months before we plan for a cataract, and have a faint corneal haze in the cases of a post C3R. So your visualization might be hampered. In the cases with a post RK or a LASIK, biometry issues can be there. The surgical difficulties as the cornea is not steep enough. Also, you need to keep a watch that how many RK incisions had been there. At times, you would find RK incisions might open up, and you might have to suture those incisions if there are more than 8 incisions that had been given. And the rehabilitation time might be a little longer than your routine phacoemulsification. That has to be very well explained. So similar thing with the post-PKP, where you would like to wait for more than a year with a full explanation of chances of a rejection and soft shell technique so as to protect the endothelium and keep a small air bubble for endothelial coating. So coming to take-home message, I would say that the central K readings from minimum 2 different machines so as to ensure that you are getting the reliable or quite a reliable readings, and a minimum 6 months stability period before we take up the patient for a cataract surgery. In the cases of keratoconus, the young patients are unlikely to require cataract surgery. However, the middle and old age patients usually have a stable keratoconus, either post C3R or with the aging. The cone, if the keratometry. In the cases of PL, sure that it's not progressing, you can plan for a customized toric IOL, which would give a very good amount of correction, but you need to very well explain that there could be a still residual astigmatism and the need for a correction. And a very important point will be adequate preoperative chair time should be given to those patients so as to solve the post-op grudges. Thank you.
Thank you, Dr. Rohit. That was a lot of details there, though the signal was not good. I would want to ask this question from both Dr. Praveen and all the expert panel. Dr. Sudhir, in a age-stabilized keratoconus and the patient is very keen on getting good results in cataract surgery, would you consider doing a topo-guided PRK in those mild keratoconus patients which are coming to us for cataract surgery nowadays? Would you want to do the topo-guided topo-guided regularization and then do a cataract surgery? And more so if it is a toric IOL which this patient wants? Your thoughts? Dr. Praveen?
Yeah, if I can go first, I think if a patient is stable keratoconus and there is no need to do cross-linking, then for correction, we would not do a topo-guided treatment and add on cross-linking. I think cross-linking and topo-guided treatments are only for those who are progressive. For those who are stable, I think if they have irregular astigmatism, then contact lenses. If they have regular, like Rohit very beautifully showed, a significant amount of correction will be achieved with either a cataract, with a toric IOL, or like Dr. Chowdhury showed earlier, also phakic IOL.
Not cross-linking, just a topo-guided regularization.
No, probably not.
Yes.
No for me also.
Yeah. No, I just wanted it as a discussion question. I missed out on some of Dr. Rohit's slides. Would you prefer to do a scleral incision in these cases or a corneal incision when you do a cataract surgery?
Hello.
Yes, Dr. Sudhir, wanted to ask you.
Yeah, I think it doesn't matter whether it's a scleral or corneal incision, as long as now with your minimal 2.2, I don't need to worry about the incisions. But in case of RK, absolutely yes. I think we only need to do a scleral incision unless until if it is a very like only 4 or 6 incisions where you have in between the space between the 2 incisions is good enough, then you can go for a clear corneal. Otherwise, the clear corneal is good enough. More clear corneal, it should be a limbal incisions.
Yes. Thank you, Doctor. Dr. Radhika?
Yeah, thanks, Dr. Rohit. Rohit is our own alumnus from Shankar Nethralaya, who's made a wonderful mark for himself right now. So nowadays, collagen cross-linking treatment has become the standard of care over long years to arrest keratoconus, and all these patients have been stopped from progressing, and they will grow older and they'll get cataract definitely. Many of them are coming for cataract surgery even now as we speak. So my question probably to Dr. Praveen is that we know that with the earlier example of refractive surgery, we did have issues with the DBR because the anterior cornea got changed, the posterior cornea got changed, and the relationship between the two got changed. And now with cross-linking, the same is happening. We're changing the curvatures of the cornea. In addition, probably we're even changing the refractive index of the cornea because of inducing the demarcation and everything. So are the current DBR techniques, requiring any tweaking when the patient has undergone a cross-linking treatment, the more of the tribe that we are going to see in the future, or because it's already an irregular cornea, shouldn't that minor difference matter at all?
I think I'll probably just make a point before answering your question, Dr. Radhika. One is the fact that if somebody has a cataract with the keratoconus and if the cataract is not significant, like Rohit showed, I will always try and do a cornea, maybe a DALC, or maybe if required even a PK before doing the cataract surgery, because I think that's where you get the most predictable and also the most accurate results. In a case where you're doing cataract surgery with keratoconus, I think very little is known from literature. In fact, we published a paper in IJO detailing what would be the right method. And it seems that the SRK2 formula, not taking any lens factor into consideration, probably is more reliable than the more modern formulas that are used for calculating IOL powers. About changing the refractive index of cornea, I think you're right in the early phase, but I think after a year or so, the effect on the demarcation line that you have with cross-linking tends to regress. So that probably would not be a major consideration for IOL power calculation.
Yes.
Thank you.
Dr. Pooja, do you want to add anything here about topo-guided regularization. We have not done in our place, but I think you all have done, no, Dr. Pooja?
Yes, ma'am. We actually, off lately, we have moved to 90% of our patients, if the corneal thickness is good, they receive topo-guided treatment for before cross-linking in the same sitting. What we do it because we have data for more than 8 to 9 years now since the time sir has started doing. What we have noticed is that patients who have received topo-guided PRK with cross-linking and versus the manual cross-linking, the chances of progression are higher.
I'm not asking. No, I'm not asking the regular. I said prior to cataract surgery.
Definitely, ma'am. I believe that also. We believe that if the patient has not undergone a cross-linking before, then you can do a topo-guided regularization with cross-linking. But if the cross-linking has been done before, then I think we do not touch the eye. We do not do a repeat treatment.
So just one thing about cataract surgery, sometimes the visualization really gets distorted. When you're doing a phaco, you can't make out, where you have to chop and where you have to actually consume the fragment. So I think for those distortions, you have to keep putting the viscoelastic onto the cornea again and again, because that kind of nullifies those distortions. And people have even described, Dr. Christopher Rupano has described the use of a contact lens onto the cornea while doing phacoemulsification, so that those distortions are taken care of.
Yes, I think in LV Prasad they have done as
in fact, the patient's own contact lens that seems to give the best visualization. Sterilize it, put a blob of visco, and then the patient's own contact lens on the eye.
Yes, right. So, anything else anybody would like to add? Because some of the questions which were not covered, or shall I conclude?
One question about the limbal versus the corneal incisions. In keratoglobus, you need to be very careful because sometimes even the limbal incisions can tear. So it's better to be a little on the sterile side if it's a keratoglobus going for cataract surgery.
Yes.
You can end up with a cruciate tear, then you have to glue it and put a BCL, etc. So that's all.
And we should suture up these wounds also.
Yes.
Ma'am, do you always suture the wounds or only if it's required?
In keratoglobus, you should, I think.
Yeah, sometimes they have brittle cornea syndrome also, and then everything that you do tends to just tear up, especially the keratoglobus.
You can have a lot of cheese wiring with the cornea coming in pies in your hands. So the cornea is left best untouched and all incisions sutured. Suturing also sometimes burying the knot, that tension the cornea does not take and it cheese wires. So that also has to be kept in mind.
Yes. So I think much of the questions have been covered. So I'm going to conclude. It's going to be 9. And so thank you very much, all of you, very respected expert panel and a great set of speakers for making it such an interesting 2.5 hours for all of us. I'm sure our attendees would have gained a lot. And I would want to again, of course, thank my ARC team for always being there to back me up. And of course, a very wonderful moderator, which I had, and who, ensured that there was a lot more content which was brought in this particular webinar. And I would take this moment to thank Mr. Kripal and the AIOS admin for always being there, supporting us. Special thanks to Sai and Manjula from Numerotech for sending these mailers on and off so that we have a good attendance happening all the time. And our very special thanks are due to Sun Pharma for sponsoring all the PG update webinars in this last 1 year. And we continue to look forward to their support over the next year. And finally, most importantly, I think our thanks are due to attendees, because that is what keeps energizing me to come back again and again. And although there have been many topics which have come this far, ectasia is the first time which has come, the second time in the last 2 years. That just tells us that so much ophthalmology has to offer, that we can still do newer topics and with small minor changes here and there. Thank you so much, one and all of you. Have a great evening, what is left of it.
Thank you
And
so
thank
much,
you,
Dr.
ma'am.
Shweta,
Thank you.
for the honor of sharing the
Yeah.
platform. And thank you so much to all the panelists and attendees for the privilege of their time. Thanks a lot.
Yes.
And
Thank
thank you, Chitra. Thank you, Chitra and Radhika, both for doing a great show.
Yeah.
Thanks a
Like
lot,
always,
Dr. Ramdhika.
Thanks, Manati. Thanks, Dr. Praveen. And Dr. Sudhir, I need to
Thank
see
you,
you
ma'am.
more often. You keep
Sure,
coming up with excuses. No excuses from you allowed. Thank you. Thank you,
Thank you.
Dr. Radhika. Thanks.